Welcome, everyone. This is another session, educational session by Dr. Weissman, and as you can see, the students in the background. So a very popular session. We do it bi-weekly. This is to help you in your rotations and even during the interviews and, just getting you used to the life of a resident, day in the life of a resident. So thank you, Dr. Weissman, for doing it, and over to you.
Absolutely. Thank you, Puan and Arati, everybody from the Sarthi team. I think this is going to be a very, very important lecture, particularly for those who are aspiring internal medicine residents, because it has so many core topics that we need to understand about inflammatory bowel disease. And what we're going to try to do is we're going to try to talk about a lot of the things on a primary care level, avoiding anything that would be like a subspecialty thing. So really things that we need to know for the office or for the hospital when we're talking about IBD. And I think this will give you a very good leg up on residency, because this is what residents know. We start off with a question. The way we're going to do this is I'm going to read through the question myself. And then on the chat, maybe everybody on the chat could just kind of put the answer that they think it is, and I'll go. Okay. So we have a 29-year-old female who comes in for routine follow-up after a new diagnosis of primary sclerosing cholangitis and MRCP. So PSC, primary sclerosing cholangitis. What is the next step during this follow-up visit? A, liver biopsy, B, colonoscopy, C, ERCP, D, start them on a TNF alpha inhibitor. So maybe we could just put it onto the chat. So people are saying B. Excellent. So what are we getting at here, right? So this talks about health maintenance in inflammatory bowel disease. There is about an 80 to 85% association between PSC and IBD. Okay, so all patients with PSC should have a colonoscopy at the time of diagnosis to look for inflammatory bowel disease. Excellent. Very good. I think we were all over this. They love to ask this on the exams. It's something we need to know regarding health maintenance. Let's continue the health maintenance idea and talk about this next question. Okay, we have a 45-year-old woman with a known history of IBD. She comes to the clinic for an annual follow-up. She's up to date on vaccinations. She's on a couple of medicines. One of them is infliximab for her IBD. Which of the following is the most appropriate? Give her the MMR vaccine, pneumococcal, intranasal flu, or stop her infliximab 3 months before vaccination. Okay, so this talks about vaccinating patients with IBD. It's a very hot topic. It comes up all over your exams and on the in-service training exam, and we need to know this at residency level. What are we thinking? So I'm looking through the chat here. People are really going for B. People are saying B as in beta. Give them the pneumococcal vaccine. Okay, so let's spend a lot of time on this. Let's talk about this. This is a very big thing to talk about. Okay, so vaccinating patients with IBD. Okay, so patients with IBD who are taking anti-TNF should not get live vaccines. Okay, so which of the following is live? MMR is live. Intranasal flu is live. Okay, and stop her infliximab 3 months before vaccination. We don't do that because she doesn't need a live. Pneumococcal is not live, so pneumococcal vaccine could be given. Okay, so intramuscular influenza would be the right answer because that's not live. So pneumococcal and influenza, very good. They love this question. They love this topic. And you see it clinically. People come to the office. Okay, next thing. Last thing regarding preventative care and health maintenance in IBD, which is a very big topic. 37-year-old woman. 37-year-old woman evaluated during a visit. Okay, she has a 3-year history of ulcerative colitis. She's up to date on vaccines. Skin cancer screening a couple months ago. Her last cervical cancer screening was 1 year ago. Which of the following is the most appropriate health maintenance to perform? Colonoscopy, anal cancer screening, cervical cancer screening, or a DEXA scan? Okay, so health maintenance in IBD patients. Some of us are saying A, colonoscopy. So a lot of us are saying A. So I think a lot of us are starting to think, but guys, when you're diagnosed, right? So we'll talk about colonoscopy very quickly, just to eliminate because it's the wrong answer. So when you diagnosed with IBD, you need a colonoscopy how often later? After 8 to 10 years later, and then every 2 years after that. So she had. So this is 3 years ago. So she should not need a colonoscopy now. Okay. So the answer is actually cervical cancer screening. But you say to yourself, what do you mean? No. The patients who, average risk patients, need a cervical cancer screening via a pap smear. How often? Every 3 years. But this patient had it a year ago. Why does she need cervical cancer screening? And this is the kicker. This is why they love this question on the exams. Cervical cancer screening is needed annually in patients with IBD because they're very high risk, especially those on biologics. Extremely high yields point. They love to test it. It's the only exception to the rule. Pap smear needs to be done annually. So that's what they like to test on the exams. Patients with IBD need an annual cervical cancer screening. So it's something that's extremely high yields. Okay. In normal risk patients, 21 to 65 every 3 years, but patients with IBD have an increased risk, even greater if they're on immunosuppressive, so they need PAP annually. Okay. Annually, they also need a melanoma screening, right? They need to go to a dermatologist annually. But she said, if you look back in the question, she said 1 year, 3 months ago, she had a skin cancer screening. So she's good for the year, right? But that could be an answer. If they said she had it 2 years ago, the answer would be skin cancer. They also need screening for anxiety and depression annually. So they can also test you on that. Okay. Very good. Let's try another question. And this has to do with already pharmacology for IBD. 22-year-old gentleman is evaluated for loose bloody stools. Colonoscopy shows moderate inflammatory mucosal changes involving the rectum in a continuous fashion with abrupt transition to normal appearing mucosa in the upper rectum. So it's limited to the rectum, it seems like. Biopsy shows it's colitis, which is always the most appropriate. Again, so this is somebody who had 22-year-old male who comes in with stools, has ulcerative colitis. Now, where is their disease? So colonoscopy shows that it's in the rectum only, because there's an abrupt transition point to normal appearing mucosa in the upper rectum. So it's limited to the rectum. What's the next step of management? Suppository of 5-ASA, oral prednisone, steroid suppository, oral 5-ASA, or 5-ASA enema. Very hard. This is a very hard question. Really on a high level. Very high level. So I'm looking here. Some of my students are saying E. We have a mixture of A and E on the webinar chat. Some of us are saying D now. Some of us are saying E. What do? You give an enema, suppository. So the answer is, so basically, so let me put it like this: you never give oral prednisone. That's always the wrong answer. Okay. You never want to start with oral prednisone. The question is, and steroid suppository is always the wrong answer. You want to give 5-ASA, which is what's 5-ASA, guys? That's 5-aminosylic acid, which is going to be the cornerstone of management of patients with ulcerative colitis. But the question is, do you give it orally, do you give it as a suppository, or do you give it as an enema? And the answer changes based on where the disease is. So let's take a pause from this question. We're going to come back to it. But the next question is very similar. So this answer was going to be suppository. It's actually going to be a suppository, and I'll explain everything why. Okay, this is called E1 disease. I'll explain you everything. Go to the next question. Very briefly, here, it's the same thing, but here, it includes the rectum and it continues action to the mid-sigmoid. So here it goes up to the sigmoid colon. So now if you have it to the sigmoid colon, the answer changes. Okay, the answer is going to be here, it's an enema, because this is called left-sided colitis. Okay, so let's go through the 3 different scenarios. There's 3 subtypes of UC. We have to know all of them, because all of them you do a little different. E1 disease means it's limited to the anus and the sigmoid. If it's ever limited to the anus and sigmoid, the answer is a 5-ASA suppository. That's the answer. That's called E1 disease. E2 disease is left-sided colitis. It goes to the sigmoid colon, but it never passes the splenic flexure. The answer is 5-ASA enema. However, if it's beyond the splenic flexure, it's called extensive colitis, E3. There's E1, E2, E3. This is E3. If it's past the hepatic flexure, splenic flexure, then the answer is oral and suppository, 5-ASA. Because you want a suppository for the bottom and oral for all around. The exams do this. This will not be on step 2, not on step 3. No, this is very high level. This is on your medicine and service training exam. This is what you need to know on a residency level. Okay. So, but if we know it now, we're in very, very good shape. Taking us to another question. Okay. So here we have a 39-year-old man who comes in for a relapse of ulcerative colitis. He was unresponsive to doses of 5-ASA. His symptoms resolved after prednisone, but once he started to taper the prednisone, his symptoms came back. What is the next step? Very common complaint that you'll get. Abdominal pain, he has colitis, he's on 5-ASA. Prednisone works, it stops his disease, but now maybe he needs something to put him in remission. because there's kinds of in thoughts. When you're approaching a patient with IBD, there's two things. You have to induce remission and maintain remission. Induction of remission and maintain remission. Two different things. So what medicine here can help them? A, azathioprine, B, AZA and infliximab, C, sertralimab. All these are biologics. Anti-TNF. D is long-term low-dose prednisone. Who thinks so? We're starting to see. So we see some B's. People are saying AZA. This wasn't me who put it in. Somebody. C is sertralimab. B, Shane, I know you from this morning. Shane is saying B. Okay, so let's go through it. This is a very good teaching point. Excellent. So the answer is this is moderate to severe ulcerative colitis. Okay, so the answer is you need AZA and infliximab. Why? Why not just infliximab? Guys, let's walk through this very carefully. Okay, so the goal in remission in these patients is glucocorticoid-free remission. You want to put them in remission, sparing any steroid agent, because steroids have long-term side effects of osteoporosis and worse, and mucosal healing. So steroids are very good for inducing remission, but they cannot be used to maintain remission. You need a maintenance drug. So why not monotherapy? The answer is all the big studies now show that combination therapy with AZA and infliximab is more efficacious than monotherapy alone. Okay, so therefore you want to use it to induce and maintain remission in patients with moderate to severe ulcerative colitis. Excellent. This is good teaching. We need to understand this. I will note that before you ever start an anti-TNF agent, what do you need to do? Test for what? TB, as well as hepatitis B, because if they're in latent TB, they could go into active. Very dangerous. You want to test them for this first. And if it's positive, you have to treat them with isoniazid for 2 months. Okay. Very good. Let's take this patient here. This is a very similar case. So we should go through it very quickly. It's a 24-year-old woman hospitalized for severe Crohn's disease and many, many flares. Her only medication is AZA, and she has abdominal pain. She's hospitalized with abdominal pain. What's the next step? Budesonide, stop AZA, start adalimumab, add infliximab, change AZA to 6-MP, change azithros to sulfasalazine. So let's follow the same logic we spoke about previously. Is what? You need combination therapy. So the answer would be add infliximab. So you add infliximab. Moderate to severe Crohn's disease, you treat it the same way as moderate to severe ulcerative colitis, which is combination therapy. Combination therapy. We spoke about anti-TNFs inducing and maintaining remission in patients with inflammatory bowel disease. Combination therapy is always more efficacious than monotherapy alone. Very good. Let's take this next patient, and we're going to wrap up talking about this case, which is a very big topic in talking about inflammatory bowel disease. And this is a 33-year-old woman with ulcerative colitis who gets hospitalized for 8 to 10 bloody bowel movements a day with pain. There's no rigidity. Her pulse is 99. What is the next step? IV steroids, IV antibiotics, start a TNF alpha inhibitor, or consult surgery. So here, some people are saying consult surgery. People here are saying steroids. And I think we really, some people are saying anti-TNF. So this is a little different. So we have to always diagnose before we treat, right? So the diagnosis here is not toxic medical, but we call it acute severe ulcerative colitis. This is severe, you see. Before we talk about mild to moderate, this is severe, acute severe. What does it mean? What makes it acute severe? We'll talk about that in a little bit. But for now, we need to know how to treat it. So the answer is acute severe ulcerative colitis is 6 per day or more. Is acute severe ulcerative colitis. It's associated with abdominal pain, tachycardia, fever, and elevated inflammatory markers like ESR, CRP. Initial evaluation, you need to rule out infection. So you want to get a C. diff toxin, a stool oviparasite. You could even do a flex sig. But that should be the initial evaluation to rule out infection. Once you rule out, the first line is always IV steroids. Acute severe ulcerative colitis, IV steroids. If they fail IV steroids, then TNF biologic like infliximab, you start them on Remicade in the hospital. If they fail that, then you have to have something called a rescue therapy or salvage therapy, because ultimately they may need colectomy, because then you have to take out the colon. They need a pouch, which is a life-altering treatment. So again, first steroids helps about 50% of the time. Now, if steroids don't work, you need to do infliximab. If infliximab doesn't work, you need to, before surgery, now they have salvage triple-line therapy of things like vedolizumab might work, or some of these small molecules, JAK inhibitor small molecules. Anybody know any of the names of the small molecules that maybe would work to prevent collecting? You heard of vedolizumab, right? That's an anti-integrin agent, which has started to revolutionize therapy. Vedolizumab has also been shown to be great for refractory third line. So first line IV steroid, second line TNF alpha. They will never test you more than that because that's very advanced GI related. But ultimately, you want to prevent colectomy. Okay, very good. That is what I wanted to talk about in all of inflammatory bowel disease. I think if you know this, you have a very good basis for understanding IBD. We have to know about maintenance, health preventative care, maintenance, when to do colonoscopy, when to screen annually for anxiety, for depression, for vaccinations. What's the vaccination schedule for these patients? About live vaccines, we have to know how you treat patients with mild to moderate ulcerative colitis, the 3 subtypes of mild to moderate ulcerative colitis, right? Proctitis, left-sided, or extensive colitis, when you give them oral suppository 5-SA, when you give them enema, or when you give them both enema and suppository. Okay, we spoke about moderate to severe ulcerative colitis, we spoke about acute severe ulcerative colitis, and we spoke about also moderate to severe Crohn's disease, how you treat, how you manage them. Excellent. I think this is a good nutshell and a springboard to understanding this level. If you're on this level, you'll have no problems in residency, and you'll be actually one of the top residents, because this is all we need to know about inflammatory bowel disease on a residence level. Thank you, Pawan. Please, if you want to have any comments, thoughts.
Yeah, absolutely. This is great to all our audience on Facebook and on Zoom. We will do this regularly. I think next week is Dr. Adam Atut. So we'll post out that link. But for those of you interested, Dr. Weissman graciously has rotations for our students. So if you are interested, let us know if you want to rotate with him. He offers a research course as well. And Arti and Sarthi, please post the link. But the big news I wanted to let everyone know is when the interview season, which is right in about 2 months, Dr. Weissman and Dr. Atut will offer mock interviews for our students. I think this is something that those of you going into the match may be very, very interested in. The link is not active yet, but if you are interested in mock interviews with Dr. Weissman, Dr. Atut, just put it in the chat and our team will be in touch. But otherwise, a great session, Dr. Weissman, and to the audience, if you have topics in mind that you would want us to cover for Dr. Weissman and Dr. Atut, just put it there and we'll take care of it. But thank you. This has been very interactive. I think this was the second session. So we plan to keep doing it and hopefully get a lot of education out to the budding residents.
Yeah, excellent. Thank you so much. And everybody can see we just finished rounds here in the hospital. So we now took a break for the lecture. So it was very good. Thank you so much.
Dr. Weissman, sorry to interrupt. Can you spend a minute or so to tell our audience on how your rotations work? So now that you have students, so how do you?
Yeah. They could also attest to this. So I mean, we try to keep it very academic between myself and Dr. Atut. We try to supplement a little bit of clinic time, a little bit of hospital rounds, and a little bit of didactics. And we try to break that up between myself and Dr. Atut. You'll spend some time with me, some time with him, and some time with the residents' didactics to really give you a feel for what residency is like. I think all the kids here, when they leave, they have a very strong feeling for what it's like to be an internal medicine resident, what it's like. They see different facilities, and they really get a good mix of things. So I think there's a good value for anybody who's interested.
Yep. So thank you very much, everyone, and thank you to your students for making time. So this is great. Any other questions? I will be there with my team. But thank you, Dr. Weissman, and we'll let you know if students have any questions for you.
Yeah, let me know. Very good and nice to see everybody, and all the best, guys. Okay.